practicing in Tiruchendur. It's my great pleasure to welcome you all for the today's session. We are honored to have our mentor in the field of endodontics, Dr. Sudharsan, um, endodontist and mentor at Dentalvibes Academy, Tiruchendur. He has done his BDS from Adipara Dental College, followed by MDS in Best Dental Sciences. He has more than 5+ years of clinical experience. His session today, Hot Pulp, a challenge to dentists, promises to be highly relevant to all of us practicing in the field of dentistry. Let us give him a warm welcome. Dr. Sudharsan, we are truly excited to hear from you. Over to you, sir.
Good morning, all. I am Dr. Sudharsan, endodontist. I am sharing this presentation to you all. Welcome to all to Dentalvibes Academy. Today my presenting topic is hot pulp, a challenging to the common dentist. The hot pulp is nothing but in the pulp, the temperature and also the infections, irritations, all are increased. Because of that, there is a highly inflammatory mediators produced by the cells, the host cells, that is the prostaglandins. These prostaglandins further irritate the pulpal and periradicular tissues, give the dentist as well as the patient severe discomfort to the treatment. Now we are all challenging in our daily practices. So how to manage these kind of cases? We will see it. First, this hot tooth generally refers to a pulp is diagnosed with the severe irreversible pulpitis with spontaneous, maybe moderate to a severe pain. These are conditions we call it as a dental emergencies. These emergency situations are both challenge in both diagnosis as well as a treatment management. Coming to the incorrect diagnosis or incorrect treatment, we can't relieve the pain. So fail to achieve the success of the treatment for the comfortable of the patient and also the aggravate the situations. The main three etiological factors behind these hot pulp. First, in the pathosis in the pulp. The pathosis in the pulp comes from the dental caries, the deep dental caries, grossly decayed tooth, and also traumatic injuries. In pathosis in the pulp, the pressure created by the pulp can transfer to the periradicular infections. It may be a periradicular lesions or periradicular abscesses, anything. It travels into the cellulitis as well as. These are all the emergency situations faced in the daily dental practices. And also the main etiological factor behind the hot pulp is a traumatic injuries. It is class 3 fractures or a vertical root fracture or a horizontal fractures, whatever it is. These are the main etiological factors. So directly injure and directly infect, directly irritate the pulpal and periradicular tissues. First, the whatever the etiology like caries or any traumatic injuries or any infections, first the irritate the pulpal and periradicular tissues. These pulpal and periradicular tissues produces the chemical mediators which is called a prostaglandin. This is coming from the cyclooxygenase and lipoxygenase pathway, mainly the prostaglandin E2. This initiates the inflammation. There are the two pathways. First is the directly lowering the pain threshold. It means the pain attains easily. The pain is at times very highly sensitized, like hypersensitive dentin. Like okay, this is a very hypersensitive, hyper pain that is the lowering the response, the lowering the threshold of the sensory fibers. We have two sensory fibers. It's a A delta fibers and as a C fibers. So both fibers are highly sensitized. it induces the pain. Indirectly causes vascular permeability that produces the edema and increases the fluid pressure within the canal and as well as the pulp chamber. It stimulates the pain receptors. We call it as a noisy receptors. Okay, we should immediately treat the patient because these are the emergency situations we faced in the dental clinics. We have to immediately treat and diagnosis are very important. In case of immediate treatment and immediate management and as well as the immediate care, we have a general guidelines for these cases, the emergency cases, mainly the severe irreversible pulpitis cases. First, we have to reduce the irritant. That is, we have to reduce the causative factors, that's etiological factors. Then followed by remove the inflamed pulp, thereby reducing the pressure created within the canal as well as the pulp chamber, and also reduce the anxiety of the patient. These controls the pain, inflammation, as well as the infections. There are two clinical situations, the common clinical conditions we faced in the dental clinics. First is a reversible pulpitis. These reversible pulpitis, mainly the patient complains of sensitivity to hot and cold. The cold usually was short duration. It's a very short pain. Emergency treatment, first we have to remove the all restorations, decays, any cracks, and if the pulp, the tooth is suitable for the restoration. Followed by the conservative pulp treatment like indirect pulp capping, direct pulp capping, or pulpotomy. These procedures to heal, to respect the pulpal tissues, to deviate from the inflammations. It cures, it heals the pulp. In the indirect pulp capping and direct pulp capping, we have to medicate the pulp, the outside of the pulp. We have to medicate using calcium hydroxide or MTA or biodentin. In any bioceramics materials, we have to heal the pulp and also do the restorations. These are the emergency treatment. In these cases, reversible pulpitis, in case of a small exposure of the pulp, first we have to see the bleeding spot. The bleeding should be arrested within a minute. Then only we have to proceed these kind of procedures. The follow-up treatments would be minimum 3 to 4 months. Retest the vitality test followed by the assessing periapical radiograph. The most common situations we encounter the clinicians are symptomatic irreversible pulpitis. It is categorized as a 3: mild, moderate, and severe. All the three is elicited by a thrombing pain. It starting with the hot beverages, but in severe cases, the cold drinks will reduce the pain. But in mild and moderate cases, the cold can last minutes or hours. If poorly localized initially, the patient can't tell, particularly within the tooth. So the spontaneous pain is a continuous pain, but poorly localized pain. This is symptomatic reversible pulpitis. This categorized as a mild symptoms, mild, moderate, and severe. In mild cases, we have analgesic, like pre-medications like analgesics. In moderate also, we have to advise appropriate analgesic cases. But in case of severe cases, we have to treat immediately. We have to take action immediately. If tooth is predictable for restoration, do the treatment called root canal treatment, or else extract the tooth. Flexible analgesic strategies for the mild, moderate, severe cases. In case of mild cases, we have prescribed the ibuprofen, and in aspirin contraindicated patients, the acetaminophen 325 mg is more than enough. But in case of moderate cases, we have to give ibuprofen, paracetamol like acetaminophen combination, and also we can give a tramadol. But in case of severe cases, we have to combine the ibuprofen, paracetamol, tramadol, and also the antibiotics, and also we give the patient anxiety reductions like benzodiazepines we can prescribe, and also we can give the steroid. The treatment protocol for these severe pulpitis, the irreversible pulpitis. First, we have to remove all restorations, caries, cracks. If tooth is suitable for root canal treatment, the pulpectomy followed by irrigation and medicate the canal in the first appointment. But here the problem is, in case of the hot pulp and the severe irreversible pulpitis, the initial procedure is a problem. Even though we give anesthesia, the pulp is very sensitized. Here we give inferior alveolar nerve block or else a buccal infiltration. Everything patient is anesthetized, but we have two fibers, right? A delta fibers, C fibers. The A delta fibers is anesthetized, but the C fibers is very sensitive, so very hot. That we have to manage in these type of cases. The first appointment, we do a pulpectomy and irrigate and medicate the canal. The follow-up treatment, continue the root canal treatment, prepare the canals, irrigate, medicate, and the root canal filling, the restoration, and followed by the review of 6 months. Assess the periodic. Here, the clinical condition of severe irreversible pulpitis, the patient is waiting in the waiting area and consuming a large glass of ice water to ache. Is the exact condition of severe irreversible pulpitis. These cases, we call it as a hot pulp or hot tooth. We can't manage because it gives a severe discomfort to the patient as well as the operator, as well as the clinicians. We can't do our procedures peacefully. What happens in these cases? Why cold water is the pain? Here the exothermic reaction happens. The temperature is higher in the pulp tissue, and the pulpal cavity is higher than the average body temperature. So we give a ice water. The irreversible pulpitis is undergoing spontaneous, moderate to severe discomfort. And also these cold tissue constrict the pulpal blood circulations to relieve the pain. This is a exact picture of the hot tooth, hot pulp. Why local anesthetics fails in the hot tooth? Mainly anatomical reasons. Most commonly the mandibular molars because of the dense cortical bone. The infiltration won't work it, so it prevents the anesthetic penetration. So it preferably we give a inferior alveolar nerve block. And also inflammation and tissue leakage. In case of inflammation, we have so much of prostaglandins, cytokines in localized area. In case of we give a anesthesia like infiltration, what happens in the localized tissue? Already the infections and inflammations, the tissue pH is very dropped, nearly the acidic pH. If we give a LA, it has a non-ionized form of base. It converts into the ionized form, thereby neutralizing the local anesthetics, the lidocaine property. That's why it doesn't penetrate the nerve membrane. And also in case of inferior alveolar nerve block, the tissue acidosis is a main culprit to block the nerve tissue penetrations. And also the inflammatory mediators produce the peripheral vasodilatation, so less concentration of the action of these local anesthetics. So systemic absorption is impacted, very much impacted, thereby increasing buffering capacity of the inflammatory. The main mechanism happens in the hot pulp here is a tetrodotoxin resistant channels. Normally, what happens in the mechanism of the local anesthetics is if we give a local anesthetics, this local anesthetics is a penetrate and enters nearby the nerve tissue and it blocks the sodium channels. These sodium channels prevents blockade of the sodium channels prevents the sodium ions enters into the nerves. Thereby, the conduction is blocked. But here in these cases, the tetrodotoxin resistant channel is mainly present in these type of hot tooth. Mostly present in the C fibers. We have two fibers, right? A delta fibers and C fibers. In these fibers, this sodium channels has a tetrodotoxin resistance channels. In these channels only, the local anesthetics going to bond. But in case of severe pulpitis, severe irreversible pulpitis, these prostaglandins, mainly the prostaglandin E2, transform the tetrodotoxin resistant channel into sensitive channels into a resistant channels. Thereby, it enhances the actually block பண்ணணும், but it enhances the influx of sodium ions across the nerve membranes more. Thereby, local anesthetics is resistant. Thereby, the patient having a severe pain in case of anesthetized A delta fibers. How to identify the hot tooth clinically? First, the most common locations occurs in the primary and permanent tooth or site of recent or faulty restorations, mainly amalgam restorations, decayed amalgam restorations. Site of recent tremors, mandibular bullars are more difficult common. And also patient with anxiety about the dental treatment. How to manage the hot tooth? The strategies behind these hot tooth. First, we have, before the procedure, we have to pre-medicate the patient. We have to pre-treatment the patient with the analgesic to reduce the inflammation, to enhance the success of the local anesthesia. First, the pre-medication strategies, the main thing is a non-steroidal anti-inflammatory drug. It inhibits the cyclooxygenase enzyme, thereby lowering the prostaglandins. First drug is the ibuprofen. It is a non-selective COX inhibitor. It gives a 600 milligram ibuprofen. It improves the efficacy of the inferior alveolar nerve block. Next is the paracetamol, acetaminophen. This is increasing the brain threshold. Thereby, it interacts with the brain through the cannabinoid and serotonergic pathways. Other common drug using is the ketorolac 10 milligram. It mainly inhibits the C fibers, C conduction fibers, thereby more resistance to the local anesthetic than A delta fibers. The selective COX2 inhibitors like rofecoxib and meloxicam are highly specific COX2 inhibitors. The longer analgesic efficacy, the longer duration of action, the lesser gastrointestinal toxicity, and lack of inhibition of platelet function and aggregations. Next is the pre-treatment with corticosteroids. These are pre-medications using corticosteroids. So commonly drug is a prednisolone. The steroidal anti-inflammatory drug is inhibiting pro-inflammatory cytokines and phospholipase A2. Is lowering the level of prostaglandin and leukotrienes very quickly, thereby reducing the inflammation. And 30 milligram of prednisolone is administered 30 minutes before the endodontic procedures to reduce the post-operative pain. It has a more sustained effect than 20 milligram of ketorolac. Another steroidal drug is the dexamethasone. It's a commonly used steroidal anti-inflammatory drug. It blocks the COX and the cyclooxygenase enzyme and the lipooxygenase pathway, and also leukotriene synthesis. There's a pre-medication of 800 milligram ibuprofen. It's a double dose of ibuprofen and 0.5 milligram of dexamethasone enhanced the inferior alveolar nerve block before 30 minutes to 1 hour. Then benzodiazepines mostly used in the anxiety patients. Alprazolam. It decreases the discomfort and enhances the effectiveness of the inferior alveolar nerve block. This is specific binding to GABA receptors, thereby reducing the transmission in the brain level. A single oral pre-operative dose of 0.5 milligram alprazolam to reduce the anxiety and improve patient satisfaction. It's an hydro sedation, the vocal sedation. You have to clearly speak with the patient to calm the patient. I will be careful to talk to them during procedure. Avoid using words like hurt, shock, etc. To use of music, aroma, hypnosis, and relaxation technique like deep breathing can be useful. Okay, now we all see the pre-medications. Before the treatment of the hot tooth, we have to treat the patients using pre-medications like analgesics, anti-inflammatory steroidal drug, and the anti-anxiety like benzodiazepines. Now, how to numb the hot tooth in the dental chair, in the clinic. Okay. First, we have to give a local anesthetic, lignocaine, 1:80,000 ratio of the epinephrine. Give a block in case of lower mandibular molar. We give a inferior alveolar nerve block, wait for 5 minutes. The lip is numb, the half tongue is numb, indicates the local anesthetic efficiency only for the A delta fibers. But we have to deal with the procedures. The patient appreciates pain, hypersensitized pain because of the hypersensitized C fibers. So we have to take our action to reduce the pain on the C fibers. Okay, this does not indicate the pulpal anesthesia. Then we have to give a long buccal infiltration of 0.5 ml of articaine. This is the alternative to the local anesthetics, that is alternative to the block, inferior alveolar nerve block, to modify the pH of the local tissues. Because the articaine contains the thiophene group. Mostly we using the amide group and ester group of local anesthetics. We commonly use the amide and the ester type of local anesthetic. But this articaine anesthetics have a thiophene group. This thiophene group easily penetrate the soft and hard tissue, and also the movement takes easily to enter the nerve perineural membranes. So these are the very efficient alternative to the local anesthetics. We can use 0.05 ml to 4 ml of articaine to infiltrate locally or buccal infiltration to modify the pH of the local tissue. It improves the permeability of the anesthetic into the bone, and also it enhances its lipid solubility. This lipid solubility decides the level of molecules penetration into the nerve membrane spread more effectively through soft tissue than to other anesthetics. It gives a better anesthesia. Okay, first we have to give an inferior alveolar nerve block. We can gain the lip anesthesia as well as the tongue anesthesia, but the pain appreciated during the procedure, we have to give a long buccal nerve block using the articaine or else using an infiltration, local infiltration using articaine. And also we can give a lingual infiltration. It blocks the mylohyoid nerve sensory fibers. It innervates mainly the mesial root of the lower molars. You have to deposit 0.5 ml in the attached gingiva, lingual to the tooth, distal, to one you are working on. Another type of injections we commonly use is the intraligamentary infiltration. These intraligamentary infiltrations, they accumulate any type of analgesics like lignocaine, articaine, mepivacaine, bupivacaine, any type of analgesic. We can directly penetrate into the periodontal ligament space. Needle is pushed into the mesial or distal gingival sulcus in contact with the tooth. We can give the injection very pressurized manner. Okay. If tooth is still sensitive, we can give a inferior alveolar nerve block, long buccal nerve block, lingual nerve block, local infiltration, but intraligamentary, periodontal ligament, all we can give. But if tooth is still sensitive, you are drilling out. The dentin is to be dressed with leather mix or pulpomyxin. Leather mix is nothing but it combines of the antibiotics and the anti-inflammatory. That is a steroidal. Antibiotic is the demiclocycline and the anti-steroidal. The like steroidal drug is the triamcinolone. In case of pulpomyxin, it has a steroidal drug dexamethasone acetate and it contains the two antibiotics. So polymyxin B sulfate and the trimycin sulfate. What do these letter mix and pulpomyxin? It has a steroidal drug to reduce the inflammation within a second, and also it has an antibiotic to destruct the bacterial cells present within the pulp chamber as well as the pulp canal. It gives the greater relief to the patient. But if the pulp is directly exposed, in case of grossly decayed teeth, or in case of fractured teeth, or in case of highly destruction in mesial caries or highly destruction in the distal caries, in case of pulp is directly exposed, the intrapulpal injection works under back pressure. It gives a 10 minutes of analgesia, so long enough to do the pulpectomy and remove the nerve. It's simply placing the local anesthetic solution in the pulp chamber will not achieve adequate pulpal anesthesia. The patient should be warned to expect moderate to severe pain during the initial phase of the injection. But this intrapulpal injection is very painful procedure to the patient, but it does not as a choice of first preference happens in the acute severe irreversible pulpitis. It should be the last options in case of open pulp. Okay. Then the most successful injection technique is a intraosseous local anesthetic infiltration technique. It has a stabinet and X tip. Okay. First, we have a drilling a small hole through the mucosa and cortical plate using a specialized instruments like stabinet and X tip, and allow the injection of local anesthetic solution to enter into through the mucosa and cortical plate and give a anesthesia to the cancellous bone. Okay? Because the dense bone, the cortical bone, prevents the anesthesia infiltration into the nerve membrane. So we drill the cortical bone and give anesthesia to the cancellous bone. Okay? In the stabinet system, we have a 27-gauge beveled sharp system driven by the slow speed handpiece. It perforates the cortical bone. Okay? It gives a pathway to the 27-gauge ultra short needle. Via this needle, the anesthetic solution is delivered into the cancellous bone. Okay? The benefits of this intraosseous injection is reported as the immediate onset of the anesthesia. The injection should be given distal to the tooth to be anesthetized. The exception to the rule would be the maxillary and mandibular second molars, for which a mesial site injection would be needed. The perforation site for the intraosseous injection should be equidistant between the teeth and is attached to the gingiva. To allow for the perforation to be made through a minimal thickness of tissue and cortical bone to prevent damage of the roots of the teeth. We can alter the anesthetic solution in case of emergency cases. In case of emergency situation, we give a twin mix. We can add a lignocaine with the dexamethasone to give a local infiltration to reduce the inflammation. Okay, we can give an not only for endodontic treatment, we also give a extraction procedure also. Okay? The dexamethasone is a 4 milligram of dexamethasone. The ml is a 1 ml, and the lidocaine, the commonly single dose of a 2% of lignocaine of 1.8 ml of lignocaine. The 1.8 ml of lignocaine with 1 ml of dexamethasone gives a twin mix. It gives a efficiently relieve pain and give a sensory blockage. It increases the pH. It increases the concentration of free base in the local anesthetic solution, because this dexamethasone reduces the inflammation immediately to reduce the prostaglandin and the leukotrienes and cytokines levels drastically, So the available free bases of local anesthetic is more to control the pain, to block the sodium channels. Coming to the management of the anxious patient, so give short morning appointments after good morning breakfast. Mainly the pre-medications with lorazepam or alprazolam should be anti-anxiety drugs should be given 1 day before the procedure and also 1 hour to 2 hours before the procedure. It's extremely short in the waiting area. Coming to the end of the session, take home message to treat a hot pulp. First, we have to see what is the etiology behind the hot pulp. We can manage a single appointment or as a double appointment. We have to segregate based on the severity of the irreversible symptomatic pulpitis. In this irreversible symptomatic pulpitis, we have categorized as a mild, moderate, severe. In case of mild, patient can manage. If patient attains cold or any hot beverages, the pain is elicited. Within 5 minutes, patient manage. Within the 5 minutes, patient can manage is a mild. But in case of moderate, the timing range is prolonged. But in case of severe, patient can't manage. Patient has a nightmares. Patient can't sleep. Patient can't eat. Patient can't speak. Patient have a very severe discomfort in case of severe symptomatic irreversible pulpitis. That is, we call it as an emergency situation in the dental. These emergency situations we have to handle using the anesthetics. Okay? In case of anesthetics and also pre-medications. First, we have to choose the pre-medications using to reduce the inflammation. First, you reduce the inflammation using NSAIDs, non-steroidal anti-inflammatory drug, ibuprofen, paracetamol, and in case of tramadol also we can use. And also we must use the steroidal drug at least one dose prior to the procedure. In case of anxiety patients, we have to give the anti-anxiety drug before 1 hour or two hours before the procedures. Coming to the anesthetics, we have to give inferior alveolar nerve block, long buccal infiltration, lingual infiltration, and also we have local infiltration, intraligamental, that's a periodontal infiltration, periodontal ligament anesthesia. The last options would be the intrapulpal injection. The intraosseous injection also is a good. Coming to the end of the session, we can, in case of mandibular posterior teeth, first we prefer the inferior alveolar nerve block, followed by the long buccal, that is a infiltration given. Then we can go with intraosseous, periodontal ligament. Finally, we give a intrapulpal. Every cases, the intrapulpal injections would be the final option because it is a very severe, painful procedure. Then, in case of mandibular anterior teeth, first we give a inferior alveolar nerve block or intraosseous. Finally, we give a intrapulpal. In case of maxillary anterior teeth, we give a labial and palatal infiltration is more than enough. In case of traumatized teeth, we give a intrapulpal injection. Finally, we give a maxillary posterior double dose. It's a single dose of 1.8 ml. The double dose of buccal infiltration, mainly near the mesial root. In case of maxillary first molar, the mesial root have a nerve from the neighbor branches. So I have a double dose of buccal infiltration and 0.5 ml at apex palatally, followed by intraosseous and PDU. Thank you. This is a root canal workshop on June 13 to 15 conducted in the Dentalvibes. Please support us. Thank you.
He left it seems, sir. Will be conducted at Dentalvibes. We'll just end the session. Thank you so much, sir, for your valuable presentation. Before we conclude, I would like to bring to your attention an exciting opportunity. Root canal workshop will be conducted at Dentalvibes Academy, Tiruchendur. Make use of this opportunity. If you are interested, kindly contact to the number displayed on the screen. I also thank Dr. Monica Vasam sir for this arranging this valuable session. Thank you all. Thank you.
Thank you.